Well, it's ironic that Scott talked about moving to Texas because that's going to be part of what we talk about as we close out the session, because we all know that people want to move to Texas, fastest growing state, Fort Worth, fastest growing city. But that's okay. Colorado's awesome. I love Colorado. So let's dive right into this so we can get you guys out of here, but also have a little bit of fun. So Medicaid treat no transport and alternate destination. So we're going to walk you through what we did here in Texas to get Medicaid to pay for this intervention. And we'll do a little bit of background on the intervention itself so that it gives you a little bit of context. Again, before I do all this, Kim, audio is okay and the video is working right?
Yes, looks great.
Okay. Awesome. So here's what we're going to do. We're going to review the rationale for doing things other than schlepping people to the ER that don't need to be there. Identify how to make the case to policymakers, which is different perhaps than making the case to the payers, which in some cases is the same. By the way, I just got off of the planning call with CMS. We have an ET3 model webinar coming up specifically for commercial payers. They've been invited to learn about how treatment and no transport and payment, more importantly, for treatment, no transport is a huge benefit to their members and to them. So if you haven't gotten that information, I think you can still register, even if you're not an ET3 model participant or a payer. Just let me know, Tim, Kim, Sean, whoever, and I'll send you guys the info that you can register for it. But anyway, so how do we make the case to policymakers? The importance of being flexible. As you guys know from doing legislation, from negotiating with payers, sometimes you ask for the stars, hope for the moon, and be happy with, maybe just the International Space Station in between. But we'll go over that a little bit. And Scott teed this up very well. Things that you're going to need to know before you move to Texas, because this is going to be very important. It'll make the transition much more smooth for you. First, save all bacon grease. You'll be instructed how to use it later. If you run your car into a ditch, don't panic. 4 men in the cab of a four-wheel drive with a 12-pack of beer and a tow chain will be along shortly. Don't try to help them. Just stay out of their way. This is what they live for. Remember, y'all is singular, all y'all is plural, and all y'alls is plural possessive. Barbecue is a food group. It does not mean grilling burgers and hot dogs outdoors. Okay, you're going to get some of these tips as we go through the course of this presentation. If you need to write these down, I'll pause. So why should you consider getting paid for non-transporting? Well, first, we all know that the current EMS economic model is jacked up. And forcing people to go to the hospital just to get reimbursed is ridiculous, and that we need to be paid for navigation, for navigating the patient to the right location. I would argue that we need to be paid for the response, irrespective of whether or not we transported someone. And we're doing that. We're doing that through the ET3 model. We're doing that with Medicaid. We're doing that with several commercial payers. And you should be doing the same thing. You should get paid for the response. And oh, by the way, the response could be an ambulance, could be a fly car, maybe dispositioning and alternately dispositioning a patient from the 911 call in the comm center, so you don't even send anybody. The bottom line is, if we mitigate a 911 response and the patient doesn't end up in the emergency room, we should be reimbursed just as if we had transported them to the ER. It makes a ton of sense, and you'll see how we try to explain that to some of the folks in the legislature as we go through that. And we need to find a more patient-centric model. If you take somebody to the emergency room with a minor lack or an ankle injury or whatever, they're going to hang out for a long time, and they're going to have a big copay. They're going to have a big deductible. They're going to catch whatever illness is floating around in the waiting room. By the way, we just got some interesting data from our large public hospital. As we continue to push for alternate delivery models here for EMS, we asked our large public hospital to tell us what percentage of the patients we transport to them by ambulance do we bring directly to the waiting room. They didn't get a bed, they didn't go into the emergency room. We literally triaged them and they went into the waiting room. And I will tell you that number from the hospital, 27% of the patients that we bring in by ambulance, we deliver to the waiting room. If that doesn't tell you the acuity of the patients that we're bringing to the ER, That's just crazy. And we are using that number a lot. We just got it last week and we've already used it quite a few times. We need to be part of the value solution, finding more value for the patient, more value for the payer, and taking every patient to the emergency room probably is not it. And then finally, what about these ED delays? We had a fun conversation with not anybody in our service area, but upstate New York. We had a conversation with an ED director who was concerned that we were going to be recommending that the EMS agency, the county EMS agency, do treat no transport, bill for it. They've got a telehealth partner that's willing to work with them. And the hospital C-suite folks and the ED director were like, no, you can't. If you take patients, if you don't bring patients here, we're going to lose money. And our ED docs are going to be unhappy and we're going to be unhappy because we're not going to get the revenue for that thing. And I explained to him, I said, I'm holding a report here that shows that the average time it takes an ambulance to get a bed in your emergency department is 94 minutes. You're robbing the community of ambulance time. So every call, every patient that they do not bring here is enhancing the services to the community. So this makes perfect sense for the patient, makes perfect sense for the community. And if you're not going to fix the bed delay issue, there's even more incentive to not bring you patients. I'm happy to report that as of yesterday, that's not as big of an ER delay issue anymore at that hospital, but we are going to continue to recommend that they get paid for non-transport. For those of you who aren't familiar with the ET3 model program, it is a model that CMS launched. Well, they officially launched it at the end of 2019. Most agencies started doing it in 2021. There's been a slow uptake, but basically it reimburses ambulance providers for not bringing patients to the emergency room, either by providing on-scene treatment in place with a qualified healthcare practitioner, nurse practitioner, physician's assistant, physician, whatever, or doing treatment on scene through telemedicine, which most agencies are doing it that way, or transporting patients to an alternate destination. And as you know, most of the times we don't get paid if we do treatment in place or if we take patients to places other than an emergency department. It was developed during 2017, 2018. It was released on Valentine's Day of 2019. Sorry, about 3 weeks before February 14th, I got a phone call, my cell phone, from the director of the Center for Medicare and Medicaid Services, CMMI, the director of the Center for Medicare and Medicaid Innovation, who we'd been working with in developing the ET3 model, Adam Bowler. And Adam said, hey, we're going to do a press conference releasing the model. We'd like you to be there. Can you come? And I said, sure. When is it? He said, February 14th. I said, Adam, you do know that's Valentine's Day. He said, yeah, I know, but we're the government. We don't have a heart. We do things on Valentine's Day, whatever. So literally they did the press conference on Valentine's Day, 2019. Part of the model originally was dispatch triage, where they were going to pay for nurses in a 911 center to do alternate dispositions. That was eventually withdrawn because the economic model for that was completely jacked up because they weren't willing to pay for the lost revenue that we would have received by responding an ambulance to a call and not transporting. We get paid for that, but they weren't willing to pay for the disposition of the call in the 911 center. And we told them that you're not going to get any applicants. And lo and behold, they got very, very few applicants. We didn't apply for that part of the model because economically it just made no sense. So anyway, right now, as of the 14th of June, 41 participants have actually implemented. In the call that I was just on an hour ago, that number is now up to 120-ish. So more participants are actually slowly getting up to speed. And 94% of the participant claims for an ET3 intervention have been for treatment in place. This is CMS's numbers. When you see our numbers, I would argue that MedStar is probably the largest enroller of patients into the ET3 model, and you'll see why here in just a moment. But the sad thing is that at the time, 41 participants that are part of this model, only 12 had submitted more than 10 claims for an ET3 model intervention. And that's scary. We as a profession need to do this to show that it's safe, that it brings value. If we want to prove that the model should change so we get paid for the response, not the transport, we all, including you all in that room, need to do more of these things. So after it was implemented, we'd been doing it for several months. The Texas legislature was about to convene. We are very blessed. I may have said this yesterday. One of the many blessings about living in Texas is the legislature only meets every 2 years for 120 days. So if you want something passed through the state legislature, you have to act fast, and there has to be no opposition. Because if there's any opposition to a bill in 120 days, it's not going to get a full vote in the House. It's not going to pass the committees, and you're done. In fact, a physician who's a state legislature told our state association a couple of years ago that the Texas legislature was created to not pass laws. It's Texas, we don't like laws, and it was designed on purpose that way. So unless you've got all your ducks in a row, all of your people lined up, and there's no opposition to any initiative, it's not going to pass. So you got to do your work ahead of time because you've got a very short time frame. So we approached the state Medicaid office, who we in our state association has worked with a lot. And we said, you know, CMS has done this thing, and you should do it too. Medicaid patients should be eligible for an ET3 model intervention. It just makes a ton of sense. We like the ET3 model intervention. The one thing we don't like is there's a telehealth requirement. In Texas, probably much like Colorado, I've been to some of your rural areas. Video telemedicine in remote areas is challenging. So we'd like you to do it without telemedicine as a requirement. And we don't want to have nurse practitioners and NPs in the field, but you should just pay us to not bring people to the hospital. And it should apply to all ambulance providers, not just ET3 participants. When we met with the state Medicaid office and we explained all this to them, and they said, this is a really good model. It makes a lot of sense. We've been on some of the conference calls with CMS, but we're not really interested. It's more work for us. We don't really see the benefit. So we're not going to do it. From a regulatory perspective, we're not going to do it. So we had to take our case to the legislature. We tried working with Medicaid, but they wouldn't do it. So we started a bit of a campaign with the legislature, with a number of local media outlets, with some of the Medicaid patients to be spokespersons and to come to some committee meetings. And pretty quickly, one of the state senators sponsored a bill. And basically it took the ET3 model and made it a requirement for Medicaid to pay for ET3 model like interventions, just like Medicaid was doing, well, just like Medicare was doing. The Texas CMS Alliance did a lot of briefings. Part of the briefing was we presented evidence during some of the committee meetings and to some of the folks, some of the stakeholders that you hear about in a minute, that showed what we were doing here, and that it was saving a ton of money. And that's really what it came down to. And this would be good public policy. And probably much like Colorado, Texas does not like Medicaid expansion. You cannot use that term in Texas at all. But we had to position this initiative not as additional benefit for the Medicaid beneficiary, but a cost savings to the state budget. And that was our sole focus. It's all about the savings. It's all about the savings. We didn't talk about the benefit to the patient. We didn't talk about patient-centered care, because we knew that the only way to win this through the legislature was to make the economic argument. Forget about the patient and all that sort of stuff, because that's what they focus on. All right, a few more things you need to know about before moving to Texas. Get used to the phrase, it's not the heat, it's the humidity. And the collateral phrase, you call this hot, wait till August. Don't tell us how you did it there. Nobody cares. If you think it's too hot, don't worry, it will cool down in December. A Mercedes-Benz is not a status symbol. A Super Duty pickup is a status symbol. Now, as part of this legislative initiative, we approached the Texas Conservative Coalition Research Institute. These folks do public policy like nobody's business. And the reason that they are generally very successful is they have a very conservative approach to their policy recommendations, and they have a lot of money. Their PAC donates to a lot of conservative legislators. So we went to them and briefed them on this model when they were developing their 2021 legislative session legislative packet. And as we explained it to them, and they went and visited one of our member state association ambulance services and looked at data and responded to a couple of calls, and they included in their legislative briefing for the legislature, which the legislature uses like the Bible, their number 2 policy recommendation was that they should pay for, the number 1 policy recommendation was they should pay this, the legislature should pass a bill that requires Medicaid to pay for treatment in place. This was the actual policy recommendation. The legislature should direct HHSC, the Medicaid office, to review and modify Medicaid reimbursement rules to enable ambulance treatment in place. And they cited, all sorts of other references and expense savings and all sorts of stuff. And lo and behold, the language that we wanted got put into this legislative act, the Senate Bill 2028. The fun thing about Senator Colcourse being the one that was the primary sponsor of this legislation is that she chairs the Senate Budget Committee. And all budgets have to go through her in order to be approved. So this was a pretty juiced legislator to initially draft and propose this legislation and end up getting, a whole bunch of co-sponsors, et cetera, et cetera. And there you go. Now, the governor's legislative budget board office did not want to run the risk of this legislation not making it through the 120-day legislative session. So what they did is they wrote a budget rider. Now in Texas, and this may be true in Colorado, a budget rider basically is a requirement to the department that it's focused on that in order for them to get their funding, they must do something for the governor and for the legislature. And this rider was added to the budget with the full support of Senator Colcourse as the budget chairman. So you can see, we didn't even have to get this legislation passed. They usurped it. They said, we believe in this so much, we're just going to make it a budget rider and we're done. It won't require committee hearings. It won't require votes. Doesn't have to go to the floor. We're good. So this is essentially the language that they put into the budget rider, which was the mirror language to what Senator Colcourse had put into her bill. Now notice that there was some specific language in here that it applies to all EMS agencies and it also applies to all managed care. Now the difference between the Medicare ET3 model and what we passed in Texas for Medicaid is that the Medicare ET3 model is voluntary and it's a model. It's not a new benefit. It's not a requirement. So the managed Medicare agencies, the payers, do not have to pay for an ET3 model intervention. However, in Texas, this is now a new benefit. So every managed Medicaid payer has to pay for treatment in place or transport to an alternate destination. So there's not the issues that we have with, who's in, who's out. Every Medicaid patient gets the same thing. So fast forward to June, and HHSC calls us up and says, hey, or sends us an email, says, hey, so the legislature is making us do this thing, and that we have to do it within 90 days of the budget passing. We have no idea what this is about. Will you help us write the rules? So a group of us from the Texas EMS Alliance drafted the rule for HHSC. When they published this draft policy for public comment, and it includes all the things that you see here, you could take a printout of the draft rule and a printout of what we sent them, hold them up to the light, and they were amazingly almost identical. So when we looked at the rules were great. And one of the things that we really focused on was they did what we asked. You do not have to do telemedicine. You don't have to do a bunch of the things that Medicare requires. You can, it says you may do treatment on scene with telemedicine, but you don't have to use telemedicine. So that was a big win for a lot of our rural agencies. And it goes into effect September 1st. It is actually now in effect. When we got the draft rules, we sent a one-page letter back to them saying, great job, thank you. We love it, we support it, there you go. And literally from the beginning of May when they first drafted the rule to September when they implemented it, was a piece of cake. They did education for the managed payers. They used the same billing codes that ET3 uses. Everything is good to go. All right, a couple more things you need to know before moving to Texas. If someone says they're fixing to do something, that doesn't mean anything's broken. The value of a parking space is not determined by the distance to the door, but the availability of shade. If you're driving a slower moving vehicle on a 2-lane road, pull to the shoulder. That is called courtesy. Weddings, funerals, and divorces must take into account the rodeo and parade schedule. So this is what was sent out to all of the Medicaid managed care payers. Hey, this is what we're doing. It went out on, as you can see, August 4th for a September 1 implementation. They use the same billing codes that ET3 is using, including the modifiers for alternate destinations, all that sort of stuff. And it's worked very, very well. And again, it went into effect September 1st. I can tell you that we have done, just in the first month, 74. Yeah, 74, I think, Medicaid treat no transport interventions. So it's already working, and we're getting paid the same as whether we transport or not. And that is a big point I forgot to mention. On the Medicare side, you get paid the same base rate, ALS or BLS, depending on the care that you provided. No mileage, but obviously that doesn't make any sense. That makes sense because you're not transporting. If you transport to an alternate destination, you get paid the mileage as well. Same thing is true with the Medicaid. So Medicaid is paying us the same ALS or BLS base rate, mileage if we transport to an alternate destination. So it works very, very well. Now, we have helped other states do the same thing. Tennessee just passed the same law. In fact, amazingly, the language in the Tennessee bill looked amazingly like the language in the Texas bill, and their fiscal, they had to do a full fiscal analysis, and you can see that their anticipated savings in this program is literally what, $7 million a year. Now, what's interesting is, and you need to keep an eye on this if you're going to do it in Colorado. Initially, the fiscal review of this in Tennessee showed that it was going to cost money because they only calculated the cost of the ambulance response and the cost of telemedicine, potentially, if agencies were going to use telemedicine. And they said, hey, it's just going to cost us more money because normally we don't pay for non-transport. So if we start paying for non-transports, it's going to cost us more. What they didn't do, because Kevin Spratland from Memphis called me right away when the first one came out and said, holy crap, they're saying it's going to cost more money. I said, well, where's the calculation here about the decrease in ER expenses? There's nothing in here about savings on the back end. So Kevin went back to the oversight board and said, you didn't calculate the, and oh gosh, you're right. So you'll notice that they published this as an update to their previous advice. And they said, due to updated information provided by the Division of TennCare, their Medicaid office, the original fiscal impact was wrong. So they updated it, and there you go. So you got to keep an eye on some of these things because people don't understand our business like we do. So make sure that you are a good resource to them. Impacts on the system. Our folks are thrilled because now the low acuity Medicaid, low acuity Medicare patients, they can offer different alternatives and we get paid the same irrespective. They're prideful because, hey, we're doing another sort of industry leading innovation. We thought that there would be a concern on the part of our field providers because economically, ET3 or payment for treatment non-transport only initially applied to Medicare patients. Didn't apply to Medicaid patients, and certainly didn't apply to commercial insured patients because at the time we didn't have any commercial insurers that had agreed to pay us for non-transport. Now we do. But oddly, they weren't hesitant about that at all. When we said, hey, you're going to have, here's the ET3 model, here's the options, here's how you do telemedicine, here's the alternate treatment things that you can offer the patient, they were fine. So if they had a Medicare patient, they said, hey, you're a very important patient, you're a VIP for us, and because you're on Medicare, we've got this option that we can do for you. We can bring a doc up on this little box and they can talk to you and to me, and we'll figure out maybe we can do something better for you than take you to the emergency department. And the crews were fine with that. When we turned on Medicaid on September 1st, they said, great, super. So now a Medicare or Medicaid patient or a Cigna patient or others, they can offer an ET3 intervention to. We don't offer it to patients that are insured by payers that we're not going to get paid if we don't transport them to the hospital because we couldn't take a financial hit by implementing this program. So that was not as big a financial hurdle as we thought it was going to be, or a cultural hurdle as we thought. We've seen a decrease in our task times. Now we are very blessed here that we don't have a lot of hospital ED delays. In fact, all through the coronavirus pandemic, and so for years, years, our average hospital turnaround time has been 22 minutes. And it's been 22 minutes like forever, even during the pandemic. But for systems that have ambulance delays, long transport times, ED delays in the ER, this is a huge benefit because now you're not tying up your one box in your rural community or a bunch of boxes in your urban community, holding a wall at the emergency room, waiting for a patient to get discharged. Because again, these are going to be low acuity patients. And when you get to the ER with a low acuity patient, you're probably gonna have to wait for a while, unless you do like we do and deliver them to the waiting room. There was a pretty significant learning curve. What we found was that the people who wanted to do it did it early and now do it often. They're our top enrollers. It took about half of our workforce a few months, some longer, to do their first one. And probably because of shaming, we do this whole big thing about, who's enrolled the most, treat no transport patients, et cetera. But once they do it, they're like, holy crap, this is like the best thing ever. And they just have to do it once, and then they'll get into the habit of doing it, and it becomes second nature to them. Additional revenue generation for us, it's generated a lot of revenue that we would not have normally generated, because if the patient AMAs, now there's two types of patients. There's the patient that's going to that truly wants to go to the ER. We say, hey, we can do something different for you, and that economically doing treatment in place versus transporting them to the ER for us financially is a wash, right? Because we would have normally taken them, but we're not. We're doing something better for the patient. That is a wash. Where we're gaining a lot of revenue is in the AMAs. That 10 to 15% of the population that's just going to say, I don't want to go. I'm not going to go. I don't care what you say. I'm not going to go to the emergency room. Okay, that's fine. But before you say no, if we do this video thing, your bill, remember I said earlier today that we bill for treatment non-transport, the bill for our response will be paid for by Medicare, will be paid for by Medicaid. If you don't allow us to do that telemedicine thing, then we're going to send you a bill, and your insurance company, Medicare, is not going to pay for it. So that bill is going to be on you. And they're like, oh, sure. Yep, let's talk to the doc. My bill paid for. So that revenue so far for us has been about $190,000 just in the first year that we've been doing this. So and that's with a pretty small utilization in the beginning. So it does generate more revenue for our patients. It's for us. It has also given us a bunch of data to do analysis on, to do patient surveys on, experience surveys, to prove to the other payers that look how often we're doing this for the Medicare population. Look at their patient experience scores, they're thrilled, and look at the expense savings that we're generating for Medicare. It's a shame that we can't do that for your members because you're not willing to pay us for not bringing somebody to the hospital. And that makes a lot of sense to the payers, and that's why more and more commercial payers are starting to agree to pay for this model. All right, the second to last thing you need to know before moving to Texas, everything is better with hot sauce or barbecue sauce. Do not honk your horn at us. It is obnoxious, and we will sit there until we die. We pull over and stop for emergency vehicles to pass. We pull over for funeral processions, turn off our music. Men remove their hats or caps. Some people get out of their car and put their hand over their heart. It's very true. I've seen that a lot here. Bless your heart is a nice way of saying you're an idiot. Now, we've all done that. We respect and consider heroes, first responders, veterans, and teachers. Here's some of the data from our program, and I spent most of yesterday in between doing this fascinating session for you guys, analyzing our most recent data. So you can see that about 14% of our patients are getting an ET3 intervention. 1,000 so far have agreed and accepted that intervention. We've used telemedicine 999 times. We use our behavioral health IES, a behavioral health line. We've used it 17 times. Only 100 patients out of the 1,000 that have been enrolled in this program ended up being transported. 91 of those went to an ER. 9 of them went to 91 went to an ER, 9 went to an alternate destination, urgent care, behavioral health clinic, etc. 92.8% of the patients were treated in place. Now, what was the Medicare number? 94%. I am convinced, although no one will tell us this on the CMS side, that we are likely responsible for like 90% of the interventions for ET3 that are occurring around the country. And that's fine. We're driving the data, whatever, that's fine. This is our task time data. So you can see that our overall task time for a telehealth call is about 58 minutes. For a regular AMA, it's about 32 minutes. So it is taking a little bit of extra time, but one of the things that we do on these calls is after the patient is treated in place, we typically will arrange a follow-up visit for them from a mobile urgent care organization, Dispatch Health, that you guys I think are pretty well aware of. So we have a partnership with Dispatch Health. They see some of our patients after an ET3 intervention to do suturing, med rec, they dispense medications and that kind of stuff that we might not be able to do on the scene. But you see the task time difference for a telehealth completed versus transport time, we're still saving about 16 minutes by doing an AMA with telehealth, getting the patient's bill paid, generating revenue for the organization, and quite frankly, just doing the right thing. What EMS should really be doing. Our future plans are expanding the participating payers. We've got our first true commercial agreement. I'll show you that in a minute. Where they're paying us for non-transport. Many of the managed Medicare plans have already contracted. So that works really well. What's cool is that, as you guys probably know, many of the commercial insurers have a Medicare Advantage plan. They learn about this process for their Medicare Advantage population, and then it's easy to flip the switch and say, hey, we should do this for our commercial payers too. So let's just add that to the agreement. We're doing a bunch of other innovative services, working with our payers, Safe Landings Program, MedStar on Demand, which is a new subscription program. I think we talked about that yesterday. And if you want to do it, you don't have to do it with Medicare. You don't have to be an ET3 approved Medicare participating agency to take this same model, go to the state legislature, make it a requirement for Medicaid. Heck, make it a required coverage for your commercial plans. We're considering that for the next legislative session. Now we've got a bunch of data. Just make it a rule through legislation, and then rule that ambulance treat no transport has to be a covered benefit for insurers allowed to sell insurance in Texas, not just ambulance transport, which is how most of them are worded. And do we now bring this into the communication center? Do we say to the payers, hey, as I said earlier, if we disposition the call and we do, say, telehealth from the 911 center. So somebody calls 911, they say, yeah, I think I, got sunburn on my feet. And those calls come in. We say, okay, hold on. Are you calling from a smartphone, iPhone, Android? Yes, I am. I'm going to send you a link. I'm going to text you a link to this number. I want you to click on the link. So our CAD can send a link, does send a link to that smartphone. The caller activates the link, gets connected with the telehealth provider. Right there, we stay on the line on the audio. They're connected to the telehealth provider. They chat. We stay on the line, and they come up with a disposition, and the patient's happy. Telehealth is fine. We drop off. We have now mitigated a 911 call without sending a resource. We should get reimbursed for that, and we're starting to have those conversations. Here's an example of one of our more recent commercial payer agreements. You'll notice here that AO 998 is a covered HCPCS code in this commercial in-network agreement. Now, remember we talked this morning about network agreements. We are in network with this payer. The reason that we are in network is because we're not balance billing, and they would only pay us the AO 998 HCPCS code if we were in network. What is interesting is that the rate that they have agreed to pay us for all those HCPCS codes are the same as we are being reimbursed today. Okay, great. Everybody stays whole. They're not spending any more on ambulance, but they're saving a boatload of money on the back end for ER claims. And what they are paying us for the AO 998 HCPCS code is identical to the AO 427 payment. When we were first discussing this, they said, great, we'll pay you $1,270 for the AO 427, and we'll pay you $309 for the AO 998. And I said, okay, that's a good offer, but I'll tell you that you'll never see an AO 998 claim, and you'll never see a reduction in the number of patients of yours that we're bringing to the emergency room, because if we're going to get 3 times, 4 times as much transporting someone than we are treating them in place, we're just not going to treat them in place. So you you have to pay us the same whether we transport or not, just like Medicare is doing, just like Medicaid is doing. And they came back literally 3 hours later by email and said, yep, how about these rates? And I said, yep, we're good. Okay, send over the agreement. We'll get it done. So stick to your guns. They get it. They do the math. It's just back of the napkin and they understand the value. All right. I think the last things that you need to know, the American, Texas, POW, and Gadsden flags are considered sacred here in Texas. So is the Constitution, all of it, not just some of it. Unless you're prepared to fight for it, your political opinion might be best kept to yourself. Most of us carry firearms. All of us carry knives. And God is sovereign, and we pray. All right, and with that, we blew through the making the case for a treat non-transport model. Kim, I will turn it over to you for any questions that folks may have sent in that I can't see because I'm screen sharing. I'll even stop screen sharing. There.
Are there any questions online for Matt Zabatsky? Seeing nothing currently online in the room. Mr. Deans has a question for you.
Sorry,
Of
Matt.
course he does.
It could be very possible that there could be similar legislation sometime in January 2023 in Colorado. If we were to do this, and taking your advice on adding it to the commercial plans in Colorado, obviously you shared the legislation with other states. Can we get your data as well? Because it's proven these are things that are happening, real live examples, savings occurring. Can we get that?
You can.
And then I noticed that your rates were blacked out on your last slide. That must be super secret. Because even if we're going to talk with our payers and with our legislature and HICPUF, how do we give them an idea of, as you're working through the savings, there's a cost and a savings, right? And to show that the cost and the savings are higher than the cost, how can we do that if we don't know what other places are getting for rates?
Because you have to negotiate it. The reason I can't share it with you is because people would say that's collusion, right? If I tell you what I can show you what we're charging all day long because there's no collusion there. If I show you what commercial payers are paying us for that service, now you've got a basis to set your rates or your reimbursement level, and there are laws against that. So I don't want to give you a document that has the rates on it. I will tell you that it's in the approximate range of $1,274.
It's somewhere in the range. Cool. Last but not least, could this be a stepping stone, or should we be thinking for community integrated health too? Because the same arguments that we use for treatment in place, TIP, as a result of a 911 call, can we not achieve the same or a similar result through community integrated health?
You can't. And here's the interesting scenario. So we have two recent lucrative contracts with one managed Medicaid payer and one care management organization that pays us every time that we go see one of their patients, either because they've asked us to, or because we've enrolled them in our high utilizer program, or our readmission prevention program, or we've sent a community paramedic to co-respond with the ambulance because that member has called 911. Molina, which is now our second largest managed Medicaid payer, has contracted with us to do that. And they love the outcomes because we have dramatically reduced ER utilization, not only in their high utilizers, but in the one utilizer that has never called 911 before, never gone to an emergency room before, but they called 911 because they injured their wrist. and we navigate them from the scene to an urgent care, or to a clinic or whatever the case might be. And they are paying us well for that. So, and they're now paying us for ET3. So they get it. Now, care management organizations are interesting. Do you guys have a lot of those in Colorado? Do you know what they are?
What's that? Yeah.
Do you know what a care management organization is?
Just organizations like that.
Yeah. Yes.
So Landmark Health is one of the country's largest care management organizations. They are out of New York. And as a matter of fact, interesting sidebar, Adam Bowler, who was the CMMI director during the ET3 model development, was the CEO of Landmark Health, by the way, before he went to the federal government. They came to Texas. They signed a full risk agreement with our largest ACO here in North Texas called Texas Health TMA, whatever it's called. Anyway, 130,000 members, the highest performing ACO in the Medicare program. But Texas Health, what do I can't believe I'm blanking on the name. But anyway,
Because it's already Friday in Texas.
Yeah. So they took on full risk. So Landmark Health's reimbursement is based on the expense reduction in that ACO population. They came to us, Landmark Health did, because THR told them, hey, we're using MedStar for some of these programs, specifically how and you guys should talk to them because their outcomes are phenomenal. So Landmark Health reached out. We met with them a couple of times. They rode out with our community health paramedics. And they were going to use MAs in our area. They were going to send MAs to do the home visits on these patients, to do some episodic on-demand care. Once they realized what paramedics can do, what protocols they operate under, what flexibility they have with treatments and all sorts of things, they said, all right, we're not hiring any MAs. We're just going to give you guys all these patients and we'll pay you $160 every time you touched one of our patients. They said, okay, we're good. Yep. And they have increased their number of patients in our programs dramatically. Hold on, my boss is bringing me something that looks
Merry
like it's from
Christmas.
North Pole. Fort Worth Police. Thank you very much. Everybody look, it's a nice shirt. Where was I? Oh, so right now we've actually promoted 2 more paramedics into our community health program and got permission to start using community EMTs because the volume for both Molina and Landmark Health, in addition to the programs that we've done for years for the hospitals that they pay us for the readmission prevention, the high utilizers, the hospice programs, the home health programs, that division within our public organization has the highest margin of anything else, much higher than the ambulance division. And it's growing like crazy and making us a ton of money. So yeah, you can certainly do that.
And so the ET3 for Medicare, that has to be from the result of a 911 call, correct?
Yes, it does.
Okay, so if someone calls 911, the ambulance responds, can a community paramedic come in and finish that treatment in place and release the 911 car to go back in service and handle emergencies?
It can, but the community paramedic still has to either bring with them a nurse practitioner, PA, or an MD, or do telemedicine for treatment in place. It can't be a community paramedic at all, or alone, I should say. And that's how FDNY is going to do their program, because they literally are going to, simultaneously dispatch a fly car to these low acuity EMD codes. The ambulance will arrive because we're not eligible for reimbursement unless an ambulance arrives on scene, but they are going to be immediately relieved to go back in service by the community EMT, community paramedic, who will finish that intervention so they can get reimbursed.
Thank you, Matt.
Any other questions?
Well, some of you are probably thinking, well, why the hell do we have to have an ambulance there? And many people have asked that question. And CMMI told us very specifically that the Social Security Act of 1965 says that ambulance transport is the benefit, not community paramedicine, not a paramedic on scene, not an EMT on scene, ambulance. So because of the statutory limitation, an ambulance must arrive in order to be eligible for reimbursement. Now they can be on scene for 2 minutes, but there has to be an on-scene timestamp for that call.
How does medical necessity fall into this? Is there any part of medical necessity or the lack thereof that would eliminate the ability to bill and be paid? Is there a medical necessity component to this?
There is for the alternate destination, but not for treatment in place. So the way that the model works is if you're going to transport to urgent care, primary care clinic, whatever, the same medical necessity rules have to apply for that alternate destination as if you were going to the emergency room. Several of us pushed back on that and said, by definition, if we can take that patient to an urgent care, they probably don't need an ambulance to go there. And they said, well, that's going to be up to your local MAC to determine medical necessity, because you still need to meet, because if they didn't meet medical necessity for an ambulance, you should arrange Lyft or Uber. And we said, well, is that a covered expense under the ET3 model? And they said, of course not, because it's not in the 1965 Medicare statute. So for treatment, for alternate destinations, yes, still needs to meet medical necessity for ambulance transport. However, there is no medical necessity requirement for treatment in place.
So have you, in the instance where you've done some ET3, you've done some telehealth, the patient could still benefit from going somewhere, an urgent care, and even if it's non-payable, have you transported via alternate mode of transportation to an alternate destination? Okay.
No, because we're not getting reimbursed for that. So why would we do something that we're not getting reimbursed for? When we did our nurse triage program in the 911 center from 2012 through 2020, we were funded by Medicaid and by our local hospital district, and they paid for the nurse, the software, and the alternate transportation. So when the nurse took a call from Sean Caffrey, who called because he had a stuffy nose, and the nurse arranged for Sean to go to the local clinic, we sent Lyft to pick him up, take him to the clinic, some cases bring him home again if that was a barrier to him going to the clinic, and all of those were reimbursable. But under this model, it's not reimbursable. Good. Payment policy drives delivery.
Right. But sometimes I was just wondering if there was, even from a demonstration model, we're so used to transporting via the most expensive means, now to a less expensive place, right? Your argument, if they could go to the less expensive place, why did they need the most expensive mode of transportation? Even if we could find that way of doing it alternate means and get paid for it, I mean, should that become part of the discussion in the future? Why does it have to be via the most expensive means to either the most expensive place or a less expensive place? It doesn't make sense.
Tim, you're right. It doesn't make sense. But remember that there's a difference between really what the federal government can do and what states can do. So states have much more flexibility. So you could go to the Colorado legislature, to Colorado Medicaid office, and say, listen, in the legislation, in the budget rider, or whatever it is that you're going to do, please put in there that the Lyft ride, the Uber ride, the taxi ride, the whatever, from the 911 call scene to the alternate destination is reimbursable. Because today, Medicaid pays for non-emergency medical transportation, right? They pay for wheelchair, they pay for medical livery. So in your model, and maybe in Texas's model, although this year our big thing is the Medicaid rate increase, we may go back and say, hey, listen, for alternate, some patients we do have to take to an urgent care, but we want to send them by a Medicaid covered non-ambulance trip. Can we do that? And write that into the legislation, and we'll do it. But we want to be reimbursed.
Scott, got a question for you?
I guess it's kind of about perception with the public and maybe with the lawmakers. So your neighbor to the west, I guess, Arizona, earlier this year, kind of made national news when the governor signed the bill prohibiting EMTs from presumptive diagnosis and not transporting patients. And clearly there were some issues and some backstory there that we might not even know yet, right? But it looked to me like it was a move in the opposite direction, at least with regards to maybe some public perception. When I read some of those articles and so on, yeah, there was those patients here and there who there was a miss, and then, you know, they had their story of, oh, I would have died, or, you know, or maybe somebody even did. But have you run into any challenges with regards to the public or lawmakers saying, hey, that's what you're here for, you're an ambulance, that's all about transporting patients?
Outstanding question. Number one, knowing a little bit about the backstory, and some of you may know, the problem in Phoenix was that the EMTs and paramedics ran amok, and they were actively convincing people not to go to the hospital, even when they really should. And the medical director was frustrated. A number of people were frustrated. And the bottom line was that they couldn't get, recording. They couldn't get some people to comply with the requests to be more reasonable with patient assessments and recommendations. So it happened to a legislator's wife, and there you go, much like you guys in ketamine. But let's not throw the baby out with the bathwater. So in most communities, if you have physician support, medical director support for being able to make that decision on scene, and they're willing to train you, they're willing to do all that kind of stuff, that typically checks the box. Now, in our system, our medical director truly trusts the paramedics and the EMTs, and we've got BLS units. And by the way, the BLS units are the ones that are enrolling the most ET3 patients because they're going to the low acuity calls. He really wanted a second opinion on the cases that were going to be triaged to an alternate destination. The medical protocol for our ET3 model is very simple. Medicare covered, it now says a participating payer. So that's the first, and it's odd to see payment and payer information in a medical directive, but it's the US healthcare system. So an eligible participating payer patient and low acuity complaint, stable vitals. That's all it says. It has some exclusions: people under 1, pregnant women, people in custody, suspicion of a high acuity medical complaint or condition, but it's wide open. So the reason that he did that so wide open was he said, I'm going to leave it up to you guys, but when you decide that a patient is probably eligible for an alternate disposition, let's get a physician to concur. And it's not going to be me, because I'm not going to be on call 24/7. So he feels very comfortable. And honestly, because I've done a couple of these interventions on an ambulance in the field, when the physician comes onto the doc in the box, basically you give a report, say, hey, you do an S-bar, this is what we got, this is what I think, here's what I think we can do for this patient. And the doc may ask the patient a question or two, may ask me a question or two, may ask for an additional treatment. We've done Zofran, we've done Toradol, we've done other things at the request of the telehealth doc to facilitate the patient staying home and going to see their doctor tomorrow. But we're doing it collaboratively with another healthcare practitioner. So the risk of a cowboy paramedic saying, hey, here's your arm, I'm going to put it in a plastic bag, rub some dirt on your nub, and hop in your car and go over to the trauma center. They're not going to do that.
Any other questions or comments? I still see nothing online. Matt, it looks like we are about ready to end the day.
Thank you guys again for this great opportunity. I love Colorado and just love Tim, really like Sean. No, I'm kidding. You guys.
He left, so you can
Oh,
say
okay.
whatever you want.
Yeah. Anyway, thank you guys. And it looks like I'll be out there again in April. So maybe we'll see some of you again.
Very good.
Thanks,
Thank you, Matt.
Be
Have a
safe.
good day. Bye.